Hi, today we're going to talk about disorders of the esophagus. This is an interesting topic because most times we don't think about mainly the conditions of the GI tract is actually esophagus, but there's going to be some common conditions that we've heard about, some conditions that we haven't heard about it, and it's good to have the background on this, especially if we have patients that come into our office and have some of these signs and symptoms, have pain into the sternum, thoracic cage, thoracic spine, and we want to find out why they may be having that pain or some of these signs that they're having. First process of digestion into the GI tract is mastication. It's breaking up of large food particles by chewing, mixes with the secretions, enzymes secreted by the salivary gland, saliva gland, and digesting large food particles. If they're too large, if we don't have efficient mastication, can cause strong and painful contractions into the esophagus. Swallowing is a reflex response. It's triggered by afferent nerves, namely trigeminal, glossopharyngeal, vagus nerves. This is a neural impulse that's integrated into some of the nuclei of the brain, namely the nucleus tractus solitarius and nucleus ambiguus. So you should know those nuclei for response of swallowing. And then the efferent tract uses the trigeminal, facial, and hypoglossal nerves to actually cause the reflex response of swallowing. Swallowing is a voluntary collection of oral contents, food materials, the bolus of food. It's an involuntary contraction of the laryngeal muscles. This action will push the food contents into the esophagus, and during this there's an inhibition of respiration, there's a glottic closure so that food material doesn't go into the bronchus. There's a peristalsis ring contraction so that the movement of bolus can go down into the esophagus, usually pretty fast, 4 centimeters per second. If you've seen imaging, fluoroscopy of that, you can see the food is actually traveling at a good amount of speed. Esophagus is an organ that's 27 centimeters in length, hollow muscular tube. There is a mixture of voluntary and involuntary musculature within the esophagus. Layers are mucosa, submucosa. Deeper than that is muscular. There's no serosal layer, meaning that there's no secretions that's associated with the esophagus. It's a muscular tube. So the mucosa is a stratified squamous, non-keratinized epithelium. It's more columnar epithelium at the gastroesophageal junction. The muscular layer, deeper layer, is striated muscle, voluntary muscle in the upper 1/3, and smooth muscle in the lower 2/3. There's been some discussion about that, if it's maybe half and half, or if that's really reversed. This is really according to Cecil's textbook of medicine. And so if you want to look into the research with that, if that interests you, we can have a discussion on that. Important anatomy structures, the lower esophageal sphincter. You may have heard me mention this in class. This is normally active, but relaxes during swallowing. That's going to be important to remember, is that it relaxes during swallowing and it prevents the reflux of gastric contents into the esophagus after it passes that sphincter. It contracts. There's 3 components. There's the intrinsic sphincter, extrinsic sphincter, and the pharyngoesophageal junction. Excuse me. The esophageal smooth muscle is more prominent at the junction, as we just said in the previous slide, closer to the stomach and to the lower 2/3 of the esophagus. So before there's neurocontrol, so if you have a patient who has an imbalance in acetylcholine, there may be trouble with contracting. So there's a release of acetylcholine from the vagal nerve ending, and this will initiate contraction. There's also a release of nitric oxide and VIP, which at the moment I forget what VIP is. I'll look that up. But it's an intrinsic, it's responsible for relaxation. It's a peptide. I remember that. It's a peptide. But it's responsible for relaxation of the lower esophageal sphincter. Also, the contraction of the diaphragm is very important. It's in addition to the contraction of the lower esophageal sphincter, it's responsible to keep the contents of the stomach in the stomach. So it's also controlled by the phrenic nerves, coordinated with respiration, contraction of the chest and abdomen. But it does act as a secondary closure of the lower esophageal sphincter, the LES. So some of the symptoms, the general symptoms of esophageal disease is heartburn. We see that a lot with the substernal burning and region of the pain wise. Esophageal pain without heartburn, we can have that also with different conditions. Dysphagia, difficulty swallowing. Usually if we have dysphagia with solid foods, it means more of a structural lesion. Solid and liquids, motility difficulty or cause. If we have things, you hear patients say, something sticking in the throat, that's going to be a cause to do some cranial nerve testing, because we may have an oropharyngeal dysplasia or dysphagia. Dysphagia can be referred to the back, to the chest, to the neck. Location of pain is not clear because of the abnormality. So use more solids, liquids. Ask those questions. If you have a patient who says, I have pain when am I eating? Was it more solids or liquids? Usually patients will have, will eat slow. They'll, if they have problems with space-occupying lesion or any kind of inflammation within the esophagus, they may choose not to eat or avoid certain foods, avoid certain temperatures. They may drink large quantities of liquids. They may see that they're actually regurgitating some food. The food is coming up. Probably not as a vomiting action, but more of a, most commonly at night when they're in the horizontal position, they'll complain of food actually coming up or having a taste in their mouth when they wake up. That's a sign of more of a proximal lesion, and mobility abnormality is later in the meal. So if they have a complaint that this regurgitation is later in the meal, it may be more of a motility problem, mobility abnormality later than more of a, let's say, a GERD problem. So it's more of contraction of the muscles within the esophagus. First condition that we'll talk about is achalasia. Excuse me. Get some water. This is opposite of GERD. This is when the LES fails to relax. This is food accumulates in the esophagus because the LES is not relaxing. We have an abnormal dilation of the esophagus, should be esophagus. We have increased resting tone of the LES, incomplete relaxing on swallowing, and deficient. We may have deficiencies in the release of nitric oxide and VIP peptide, visceral something peptide, and defectives and deficiencies in that. The treatment, unfortunately, we can't really do a lot with this in our office. Possibly manipulation may help with this as a secondary treatment, but usually they have a pneumatic dilation of the sphincter, which can be quite painful. Incision on the muscle, so taking out some of the sphincter muscle to relax it, or to inject actually Botox to inhibit some of the acetylcholine that causes responsible for the contraction. You've heard of GERD before. This is when the LES is incompetent. It does not contract as much as it's supposed to contract because of different reasons. Permits reflux of acid into the contents of the esophagus, so it's the opposite of achalasia. So most GI disorder causing patients to seek a physician, causing heartburn, esophagitis, ulceration, stricture due to scarring. So it causes a lot of inflammation within the esophagus and at that juncture. The definition is weakly heartburn or acid regurgitation. So it usually is very, very chronic. 10 to 20% of the population is suffering from it, so it's very common. Lower percentage in Asia. Risk factors we'll talk about is obesity, also age, especially with acetylcholine deficiency, where we may not have the contraction later on in age. Could there be a genetic component also? Maybe, maybe not. There's some research saying that there is some similarities in genes that could be causing that. Most of it maybe is an imbalance in acetylcholine. Big one also is going to be obesity here, because the increase in fat material or fat accumulation into the stomach will change actually the vector of the stomach and cause relaxation of the lower esophageal sphincter. So GERD protective layers that, again, maybe do not work with GERD or gastrointestinal reflux disease is the LES, which is not relaxing. I'm sorry, it's not contracting where it's supposed to contract. The diaphragm, which is a secondary barrier, could not be as strong or changed by possible obesity. We could have an injury to the pharyngoesophageal ligament, or the angle of His could be changed also by obesity. There is also the pathobiology of GERD. Again, it's a transient relaxation. It gets worse and worse, though, if not treated, or if it's very advanced. There's a automatic low-level resting pressure, so most of the time it's not contracted the way it should be contracted. There may be a secondary morbidity of a hiatal hernia that we may see, and then we can talk about obesity also. Obesity will change that. Gastric pressure will change the angle of the stomach anatomically, and will also cause hiatal hernia and make the GERD worse too. So usually that's the culprit. I would say 40–50% of the time. The clinical preparations or clinical presentations, for this is chest pain, that substernal pain that we talked about, dysphagia, odynophagia is painful swallowing or painful eating, cough, laryngitis, asthma, dental erosions because we have that reflux of acid that actually comes up. It may go up all the way up to the oral cavity or mucosa and actually erode the teeth. And that's more for advanced GERD. We are also, with more advanced GERD, we could have erosions and ulcerations right at the gastroesophageal junction, fibrosis, scarring, stricture up into the esophagus. We could have columnar metaplasia, Barrett's esophagus, again caused by some of the erosion and healing. And then that's after Barrett's esophagus could cause esophageal adenocarcinoma also, but that's less common. It's very uncommon, but still a possibility after Barrett's esophagus. Treatment for this is usually H2 receptor blockers, proton pump inhibitors. Surgically, if those are not working, the fundus is wrapped around the lower esophagus, but symptoms often return after the surgery also. we could also repair the hinal hernia with this. A complication of GERD is peptic strictures. Again, remember that sometimes with GERD we actually have scar tissue that's formed, fibrosis, with the esophagus. What this does is it decreases the motility and actually shortens the esophagus also. There's less compliance of the lumen, less elasticity of the esophagus. The imaging that we want to do for this is barium radiography. Remember that the barium radiography will give the anatomy, the structure of the esophagus. We may want to get some visual with an upper endoscopy with this, but usually doing a barium radiography is going to be the imaging of choice. Barrett's esophagus is a severe esophageal mucosal injury. It's a metaplastic change in the lining of the distal esophagus, so right at the junction with the esophagus and the stomach. The normal squamous epithelium is replaced by columnar, so that's due to the erosion and the ulcering of the, or ulcerations, I should say, of the esophagus. It can lead to esophageal adenocarcinoma. Barrett's is found with people, 5 to 15% of patients that actually undergo endoscopy, especially with diagnosis of GERD. Barrett's is automatically found with 5 to 15% of those patients. And then also there's association with intestinal metaplasia. Treatment here is very similar to treatment of GERD with protein pump inhibitor, anti-reflux surgery, endoscopy biopsies, and also sometimes surveillance, just to see if things will worsen or if healing will actually commence and that epithelium will actually stop and actually turn into more of the correct epithelium. As I said before, there's a risk of developing the esophageal adenocarcinoma. That risk is very low, actually, but still is a possibility and one of the reasons to do surveillance with this. Talk about esophagitis. Esophagitis, there's different kinds. The first kind is eosinophilic esophagitis. This has to do with the allergic reaction to the esophagus or to certain food chemicals or molds or allergens that may be into the air. This can trigger a chronic inflammation. Again, this is more common in children, adolescents, and also if there's a family history of any kind of allergic disorders, eosinophilic esophagitis can be seen in these patients. Again, more common in children. We often see dyspeptic symptoms, most like GERD, that burning in the substernal area. Adults will have solid food dysphagia, food impaction, and chest pain. We want to do a visual of the esophagus, so doing an endoscopy, seeing some of the linear furrowing that we normally see, multiple rings. This is normally because of scar tissue, because of the infiltration of the eosinophils. And then we can do biopsies to confirm the diagnosis of eosinophilic esophagitis. You can also see with lab results that eosinophils will be increased with this too, and that should spark our brain to say, oh, there's probably an allergic reaction because of the high eosinophils. Usually, again, allopathic treatment is topical or systemic steroids. Of course, it's not a cure for anything. We're not finding out actually what we're actually sensitive to. So that's why I said, okay, what else? So we should really find out what we're actually sensitive to. And that's why in class I'll talk about a great test called the ELISA-ACT test. ELISA-ACT biotechnologies, lymphocyte reaction assay. Will tell us actually what people may be sensitive to, food chemicals or mold. It's a very good test for chronic inflammation or chronic sensitivities into the body. Sometimes you can also get pill-induced esophagitis because of the acidity of the medication, or sometimes the basic or alkaline medication that we may be taking. They give some erosion to the esophagus or inflammation to the esophagus. We may also have a accidental toxicity of another liquid, if it's antifreeze or other household cleaners. Sometimes we have children drinking that, thinking it's Kool-Aid, and we have to act on that because that will cause a lot of irritation to the esophagus. So that's what we're talking about here, either liquids or solids, buttons, batteries. Fortunately, we haven't had that with our children, but it's very unfortunate for children. I've known parents that have had that happen. It's very unfortunate that does, but usually they come out very, very good. Let's talk about motility a little bit of the esophagus. Talk about esophageal motor disorders. Again, remembering that 1/3 is going to be the voluntary muscle. The bottom 2/3, is going to be more smooth muscle, involuntary muscle. So we could have oropharyngeal dysfunction. This is the top portion of the esophagus. We could have cricopharyngeus, inferior pharyngeal constrictor, caused by both myopathic and neuropathic disorders. If these are not constricting, or if they have a constant constriction, it can be caused with comorbidities, myasthenia gravis, brainstem disorders, ALS, Parkinson's, people who've had polio, which fortunately is decreasing in time. Major one is thyroid disease also, dermatomyositis, and then some medications also. Some people with taking medications for a long time will have problems actually having contraction with the cricopharyngeus or any kind of constrictor muscle within the oropharyngeal junction. So the presentations that we'll have is dysphagia, coughing after eating, hoarseness, aspiration pneumonia. Sometimes because of the lack of constriction, we'll actually not have that reflex of the glottal fold actually blocking the bronchi. We may actually have, we talked about achalasia beforehand. Again, it's a hyperactive or hypertensive LES. We have incomplete relaxation. We have too much contraction. We have air peristalsis of the esophageal body because of the dilation, and because muscles, they are being stretched out. They're not, after a certain point, they really can't contract anymore, so they lose their contractility. They lose their elasticity of the other layers. Again, commonly this is 25 to 60 years of age individuals. Usually there is a cause of it being the antibody-mediated autoimmune pathology. Sometimes a viral cause is suggested, but that's not really proven in research yet. Sometimes there's a selective deficiency in nitric oxide that's related to the lower esophageal sphincter. Clinical manifestations, again, dysphagia, both solids and liquids. We may have regurgitation because we're not actually having those food materials enter into the stomach, or not all of them are entering into the stomach, I should say. Chest pain because of the expansion and dilation of the esophagus, heartburn because we're actually stretching out those tissues. Testing can be done to test the motility of the stomach, how much it contracts. Manometry is going to be, esophageal manometry is going to be test for the motility or the contraction of the esophagus. And then also we're going to have, we can do imaging, order of barium radiography, and see a bird's beak, which if you can imagine, I should have a picture of this and I don't, I apologize. But if you imagine the dilation of the esophagus going down into kind of a bottleneck, that's going to be the end of the bird's beak. We may also have a neoplasm that's presenting. It's actually mimicking a primary achalasia. Can produce an autoantibody and an autoimmune reaction. And then metastasis from gastric carcinoma can also give a secondary achalasia with that. So neoplasms in the thoracic cage can cause those same symptoms and mechanism. We can have kind of the opposite problem in the mid-esophagus is the diffuse esophageal spasm. Again, this is not well understood. There's a lack of relaxation. There's a loss of control of the contraction or peristalsis of the esophagus. Obviously, there's a lot of esophageal pressure with this, and we have these violent, rapid velocity contractions that have to do with this. Again, intermittent chest pains, they can actually feel the contractions with this. They'll have trouble eating, getting things down. They may also have that regurgitation. Because of the spasms, they'll have the thickened walls of the muscular layers of the esophagus. We can see that through ultrasound of those very easily with of the esophagus walls. Again, opposite of achalasia is the spasming, but we can still see the increased contraction with esophageal manometry also. Barium radiography will show a corkscrew esophagus because of the rings of the muscular layer will be very prominent within the esophagus. Structural abnormalities of the esophagus also, again, these are where the motility or the contraction problems are very active. These structural abnormalities are very passive. They're not going to have the activity as the contraction problems that we just talked about. We can have cricopharyngeal bars, which are problem impressions of the cricopharyngeus. Again, this is the inability to relax the upper the upper esophageal sphincter maximally. So it's the inability to relax. They have a deficiency in nitric oxide and gradually causes fibrosis because of the contraction and obviously having trouble solids more than liquids. We could have a esophageal diverticula. We saw a example of this with our imaging lecture. This is above the upper esophageal sphincter, can be mid-esophagus or just above the lower esophageal sphincter. We'll go through some examples of these. First one, Zenker's diverticulum. It's just above the upper esophageal sphincter, that Killian's triangle. I will get you a illustration of this also. What makes up Killian's triangle is the inferior constrictor muscle and the cricopharyngeal muscle with that. So it will fit in between those two muscles and cause the diverticulum. So it's caused by an increased hypopharyngeal pressure. And again, that increase will cause decreased compliance and impaired opening of the upper pharyngeal sphincter. That pressure has to go somewhere, so it causes the diverticula. We'll see dysphagia with solids or liquids. We'll see halitosis because usually with diverticula there's bacteria that's growing with this, and we'll see regurgitation of undigested food and aspiration. We may see pneumonia with this also, this diverticula. Mid-esophageal diverticula is a very focal outpouching in the middle of the esophagus. It's associated with abnormality and motility, so we may want to do the manometry also to see the contraction of the esophagus. Dysphagia without regurgitation, so we'll have trouble eating solids, liquids, and we want to see the structure. So with all of these, especially with the structural deficiencies, we want to do a barium contrast, to see the structure. The epiphrenic diverticula is the herniation of the mucosa and submucosa. May be caused by a functional obstruction. Again, more of a motility, abnormality of contraction within the esophagus, but the diverticula is going to be secondary to that. Or there may be some sort of space-occupying lesion that's causing increased pressure within the esophagus, maybe a bad surgery, stenosis with fibrosis, or we talked about some other tumors that could be increasing some of the pressure and then cause a diverticula. Again, a lot of these conditions would be here maybe presently at the same time, concurrently, and cause problems at the same time, and cause different conditions at the same time. Epiphrenic diverticula, and we're talking about the lower esophagus here, will cause dysphagia, regurgitation, adenophagia, which is painful swallowing and eating, painful swallowing, substernal chest pain, heartburn, aspiration, and then imaging. Again, barium, direct visualization is the endoscopy, and then we talked about the manometry of the esophagus will show us the actual contraction of the esophagus. And then other tissues also, as we get into the stomach, we can do that same thing, that same test for the stomach. Rings and webs, usually this is more common into the distal esophagus. Schatzki's ring is a thin, fixed, membrane-like narrowing circumventral just above or right at the gastroesophageal junction. It can be at the proximal border of the hiatal hernia. Congenital, it can be genetic. A lot of these conditions are due to anatomy deficiencies, or it can be due to some weakening of the anatomy due to GERD. Again, this is more, as you can visualize here, more of a structural problem, and barium radiography would be the appropriate imaging to be ordered. We can also have muscular rings, a lot of times due to the constant contraction of some of the rings or some of the muscles of the esophagus. We can form muscular rings. This is located several centimeters above the squamocolumnar junction. This is composed of mucosa, submucosa, and muscles, so the whole layer of the esophagus. And again, our primary first imaging is going to be barium radiography, and also, especially if we want to see any kind of ulcerations or erosions, any kind of abnormal tissue material, we want to do an endoscopy. Esophageal webs are thin, eccentric, membranous areas of narrowing. These can be anywhere in the esophagus, but most commonly into the proximal esophagus. And then these are associated with systemic diseases also. Bullous skin diseases, these are mostly autoimmune diseases with bullous skin diseases. Not usually seen in the U.S., very rare in the U.S., but more commonly in other nations. Chronic graft or host disease, but probably most commonly with very, very advanced iron deficiency. There's actually a syndrome called Plummer-Vinson, V-I-N-S-O-N syndrome, where very advanced iron deficiency can cause esophageal webs, and can cause Plummer-Vinson syndrome, and then that's obviously will have to have some sort of surgical intervention with that. Hernia, hiatal hernia, there's certain types, different types, hernia of the elements of the abdominal cavity through the diaphragmatic hiatus. So usually either there's a widening or injury to the diaphragm. Again, there's three types. The first type is sliding hiatal hernia. This is through the gastroesophageal junction, mostly caused by GERD, or on the flip side also, GERD can weaken the contraction of the diaphragm grip on this, and then also cause hiatal hernia. So either way, type 2 is a true paraesophageal hernia. It's a esophageal junction is in the correct position. So we have the LES that's actually right there at the diaphragm, but then part of the stomach is herniated up through the LES. This is very uncommon to have this. Usually we have type 1, or possibly we have type 3, which is a mixed paraesophageal hernia, where the esophageal junction, the LES, and the fundus are herniated, and that is much more of a emergency hiatal hernia. But I've had patients that have actually lived with a type 3 hiatal hernia for many, many years, and just kind of live with the distress, live with the pain, live with the epigastric pain, the chest pain, fullness, shortness of breath, and just say, hey, it's normal for me. A lot of this can be caused by iron deficiency anemia, but also can cause iron deficiency anemia also, because now we're messing with the secretion of hydrochloric acid that may help with the absorbency of iron. But we may also see linear gastric erosions, because now we have a kind of a pool, or a, how do you say it, kind of a collection of, more of a collection of acid. So a lot of that acid could actually erode the gastric mucosa in certain areas with type 3 hiatal hernia. And then we have systemic diseases that involve the esophagus. Scleroderma, again, very unfortunate condition that we have that's present in society. 90% of scleroderma patients have esophageal involvement. If you remember that, we also have peristalsis in the distal 2/3. Again, this is more of where the not the voluntary striated muscle, but more of the smooth muscle that is located here, associated with neuropathy, myopathy. And again, we may have deficiencies in the actual contraction, and could cause dilation of the esophagus in those areas. We may also cause failure to contract the LES, causing GERD, Barrett's esophagus, eventually strictures, fibrosis and scarring that's happened after GERD, delayed gastric emptying because of the decreased peristalsis, the aperistalsis that's happening. And then the esophagus stasis could also harbor an overgrowth of candida and spread that infection into the esophagus. So esophagus is actually one of the harbors of candida. We don't usually find it into the stomach just because of the pH of the stomach, but sometimes if we have those borders kind of relax enough and chronically, the candida can actually spread from the intestines up and then into the esophagus. Amyloidosis, again, another neurological problem that causes aperistalsis. It could be hypotensive LES, causing a motility problem, dysfunction, problems with lack of motility, could cause esophageal rigidity, especially into the mid and upper esophagus. Again, the treatment is aimed to underlying systemic disease, but also because of the comorbidity of GERD. Usually, there's a high dose of proton pump inhibitors because all of the acid is actually going up from the stomach into the esophagus with amyloidosis because we don't have contraction. Again, this is similar to scleroderma. The dermatomyositis involves the upper esophagus, the striated muscles. So we're talking about the upper 1/3, and the oropharynx and proximal esophagus. So when we're talking about the proximal esophagus, just to make it clear, we're talking about the upper esophagus. So the distal esophagus is more the lower esophagus. So it's just the terms here. And dysphagia and loss of normal peristalsis and swallowing. So sometimes skin diseases and fibrosis within the skin, and we'll get that in dermatology. We'll see examples of dermatomyositis can actually cause internal disorders, especially with the esophagus. This isn't as common as, let's go back to amyloidosis and scleroderma. Scleroderma is going to be very, very common. Dermatomyositis is going to be not so common to have that inclusion with the esophagus, but it's still possible. Lupus can also have association, but again, not as common. Sjogren's syndrome, if you've gone over Sjogren's syndrome, you know there's a deficiency in tear production, in salivary gland secretions. There's also a reduction with that. Secondarily, there can be a reduction of peristalsis into the esophagus. Remember the first part of the lecture we talked about that secretion will actually cause some peristalsis into the peristalsis of the esophagus. So because of that, because there's reduced peristalsis and contraction of not only the esophagus but also the LES, we can have GERD, esophageal ulcers, possible infections. Remember, the esophagus can be a harbor of overgrowth of candida at times, or a lot of patients are taking medication for LES, medication-induced esophagitis, very painful or very damaging medication, but also for LES, we have a decrease in the immune system, so a lot of times they become immunocompromised. And Behçet's disease, I love to say that, Behçet's, I think that's how you say it. Some people may say Behçet or Behçet or whatever, but I think my wife lived in France for a couple of years, so she would probably say Behçet's disease. Anyway, esophageal ulcers is what you want to remember with Behçet's. Usually, with the esophagus, we're going to see ulcers with Behçet's disease. Now, it's not just limited to the esophagus, but we usually will see ulceration of the GI tract. And actually, the esophagus would be one of the last parts that you'd actually see Behçet's disease, I believe. It usually will start into the colon and then up into the small intestine, and then end up into the esophagus. So with more advanced Behçet's, I think we would see ulcerations with this. And again, you're going to see it more into the middle third of the esophagus. And Crohn's disease, again, uncommon involvement, but only really with advanced Crohn's disease. With Crohn's disease, you could see it with, again, getting into the junction between the small intestine and the large intestine mostly, and then up into the small intestine. It usually doesn't go further than the duodenum, but with very advanced Crohn's disease, it could cause esophageal ulceration or actually go up into the oral mucosa. There's some case studies about that. So because of that, and because of the ulceration, because of the scar tissue that's actually formed by Crohn's disease, it can cause strictures, fissures, esophageal bronchial fistulas, which is very, very unfortunate, and then mediastinal abscesses because of the ulceration. So, Ehlers-Danlos syndrome, you probably know it's a connective tissue disorder. Loss of collagen causes very easily hiatal hernias, very common with that. Also structural esophageal defects. Usually we see these very large epiphytic diverticulae. We talked about that. It'll cause a huge dilation of the esophagus because we've lost or we have a deficiency in the connective tissue in select organs, sometimes the esophagus. And then very fragile esophagus also. Sometimes we have a spontaneous esophageal rupture. So again, much caution has to be paid to people that have the unfortunate genetic disorder of Ehlers-Danlos syndrome. I actually had a couple of patients that I treated pretty successfully with acupuncture to help relieve some effects of Ehlers-Danlos syndrome. So hopefully it helped out. Skin disorders involve the esophagus. Lichen planus is a very chronic disorder that is caused by a lot of times sensitivity to certain allergens, but can cause with the buccal mucosa to be white and to have a thick tissue to it. So the oral mucosa, the esophagus, conjunctiva, nose, stomach, bladder, anus can have not only some scar tissue, but kind of the whiteness that we usually see with lichen planus. So again, the symptoms that we'll have is strictures, dysphagia, painful swallowing, weight loss with this. Other skin disorders, again, some of these may not be as common. Pemphigus vulgaris is one of those. I mentioned the bullous, the bullous or the skin conditions that cause autoimmune skin conditions that cause very large vesicles or bullae or bulla. That's one of them right there is Pemphigus vulgaris. It actually separates some of the superficial layers of the skin. Same thing with mucous membrane pemphigoid. That's more of an internal autoimmune disease with that. And then dystrophic epidermolysis bullosa is a very unfortunate condition where we actually have breakdown of the skin with that. So esophageal infections that we should know about, especially with immunocompromised patients. These will present with very severe, very painful swallowing and eating, multiple ulcers because of the infections, very fragile mucosa, will very commonly cough up blood with herpes simplex virus. Most commonly the distal esophagus with this. Candidiasis, we already talked a little bit about this. Again, very common with HIV patients, impaired immunity. Sometimes the people taking chemotherapy may have infections with candidiasis in the esophagus. Sometimes with motility problems, with lack of the peristalsis, they may make it a harbor of overgrowth of candidiasis. We want to do an endoscopy to see this infection. Again, with most of the tissue that may have an infection of candidiasis or overgrowth of candidiasis, we're going to see the yellow-white mucosal plaquing. That's very common with that. Cytomegalovirus. First time I heard of cytomegalovirus was with Dr. Prakash. And what I know about it is that it's very common in HIV patients or immunocompromised patients, malignancy, transplant patients, and so we may see infections that actually cause ulcers, again, within the esophagus. Bacterial esophagitis, again, very uncommon. We usually see more people that are immunocompromised with more candidal esophagitis, or sometimes, I was going to say eosinophilic esophagitis, but that's not infectious esophagitis. Usually, again, we're going to see neutropenia. We can't fight off the bacteria if we don't have neutrophils, but also malignancies or going through treatment of chemotherapy and radiation. The imaging will show extensive erosions because of the infection or of any kind of immune cells that are trying to fight off the infection. Most times they will use chemicals that will actually kill off the tissue with that, so sometimes that will cause erosions too. Human papillomavirus, again, this is very common and seen in the media with cervical cancer. Again, a lot of it can be very asymptomatic. This is more of the mid and lower distal esophagus. Usually with the endoscopy, we see these macules that are very, very red, sometimes white plaquing and nodules. Corlocytosis and giant cells. If we do a biopsy here, they'll be due to the viral infection. And of course, HPV, we have a risk of other cancers, but also a risk of squamous cell carcinoma into the esophagus with human papillomavirus. So again, got most of this information from Cecil Textbook of Medicine. We also want to review Ganon's review of medical physiology. It's one of my favorite review medical physiology books, in addition to Guyton's also, of course. But that's all I have. That's my time. Thanks for listening. Thanks for watching the video. And we'll see you next week. Have a great weekend. Thanks. Bye.